Good morning, everyone, and welcome to Got a Problem with Your Knee? Ask Dr. P. Who is Dr. P? Dr. P is a board certified orthopedic surgeon, sports medicine specialist, and regenerative specialist here to answer your questions about knee pain. Be sure to join our group, Got a Problem with Your Knee? Ask Dr. P. Submit your questions and get them answered live every Wednesday between 9 a.m. and 10 a.m. We got a whole lot of questions to get to today. So without further ado, I'm going to introduce Dr. P.
How are you? Good morning.
Good
Can you hear
morning.
me?
I
Awesome.
can. All right. Let's get started. We got a wonderful list here. So after last week's Q&A session, one very obvious question that we missed and that many people asked about was, what is knee repair, not knee replacement?
Okay, great question. The simple answer to that is that knee repair, not knee replacement, is a trademarked system of programs that we utilize your own body's healing ability to help heal yourself, as opposed to a knee replacement with metal, plastic, and cement. And not only do we use your own body's ability to heal itself with regenerative medicine techniques such as PRP, platelet-rich plasma, which we talked about, bone marrow aspirate cells, which has stem cells and other cells that help the stem cells. But we also use other treatments such as MLS healing laser therapy, which we can talk about. We also use genetic-based nutrition so that you can be on the best anti-inflammatory diet that's specific for your genetics. We use not only healing laser, we use red light laser, which helps remove fat and inflammation from your body with a nice side effect of losing weight if you need to lose weight. And then we also utilize total body fitness, not just focusing on the knee, but on the whole body, all the areas around it, and really getting a feel for what also may be contributing to that, knee pain. And so the goal is to repair the knee or help your body repair yourself as opposed to replacing it. That's kind of the simple answer. I mean, the history behind where that terminology came from is we did talk last week a little bit about the French orthopedic surgeon, Dr. Hernigot, and how he basically did a classic study looking at 140 patients who needed knee replacements on both sides. And they did a knee replacement on one side and they did the bone marrow stem cells on the other side, including injecting into the bone where the bone can get these soft spots. And if you get a soft spot, it doesn't provide support for the overlying cartilage. And when the cartilage on the end of the bone wears down, that's what arthritis is. So what they found was that after a minimum of 10-year follow-up, 82% of the people who had the stem cells never needed a knee replacement, which is pretty amazing. So my journey on that started in 2014 when I had a patient come in who was in his 40s and he had been told he needed a knee replacement, but luckily the knee replacement surgeon he saw said, "No, I think, there's really no arthritis in your knee. You just have these soft spots, these microfractures, or I don't even know if the doctor knew exactly what they were, but these big white areas on an MRI. Maybe one of these shows will show what an MRI looks like, but on the MRI, the bone should look kind of blackish grayish, and there's these big white spots that you see. And when you see those, those are areas of stress or microfracturing. And at the time, I didn't know what to do for those. But long story short, I heard about a procedure where you could inject calcium phosphate bone substitute into the soft spot because our bone is made out of calcium and phosphate. And it would set after 10 minutes and it would harden up and it would firm up that area. And so I went out to Indianapolis. I got trained on that procedure and we performed that procedure, which is a minimally invasive procedure on that patient. And he was able to, that was 2014, he still has not undergone a knee replacement. As a matter of fact, he developed the same problem in his other knee 5 or 6 years ago. We did the same procedure on him. And that is when I started to tell patients, hey, we can repair your knee and not replace it because we're repairing the bone. Now, nowadays, we're repairing even more than just that, but that's the main premise is the bone gets these soft spots, which causes pain, and it also causes the arthritis to progress faster, and people who get these stress or microfractures are 9 times more common to go on to need a knee replacement. So I did several of these calcium phosphate procedures, probably like 600 of them to be exact or over, and the patients did very well. But we took it to the next level when I learned more about Dr. Hernigo's study, and instead of using an artificial calcium phosphate, which your body has to replace, we started taking bone marrow cells from a good area of the body, the pelvis, which is really easy to access, and then injecting those into the bone of the knee or wherever else it's needed, where there's not as many good stem cells as we get older. So that's a short answer and a long answer to that question.
Awesome. Um, you kind of got into it a little bit, but I want to get a little more specific. What exactly? So you mentioned like some of the components of the knee repair, not knee replacement program. Um, what is PRP?
What is PRP? PRP stands for platelet-rich plasma. So in our blood, we have red blood cells, white blood cells, platelets, antibodies, proteins, fluid, all kinds of different things. And the platelets are those things that when you cut yourself, you form a scab. They come in, they form a scab, and they stop the bleeding, so you don't bleed to death. So that's very important. What they also
That is
do is,
important.
if they just formed a yeah, if they just formed a scab there and they stop the bleeding, well, how are you going to heal? Well, the way you heal is the platelets have growth factors. So they form a scab, they release those growth factors, and those growth factors stimulate new blood vessels and cells to come in the area to help it heal. So we've known for years and years and years that platelets have healing growth factors. And even in the 70s, 60s, 70s, 80s for sure, people started using originally for dental, then for ENT, ear, nose, and throat, and then for plastics, and then eventually for musculoskeletal orthopedics. Uh, the patient's own blood by taking some blood from a vein in the arm, and usually it's not as much blood as you would give for a blood donation. So a blood donation is about a pint, 300 cc's. Really, it's about 60 cc's. Sometimes it can maybe be up to 120 cc's of blood. So it's not a huge amount of blood that we draw, but we take that blood and then we put it into a centrifuge, which is kind of like a washing machine. It spins around really fast. And then the red blood cells, the white blood cells, the platelets, the fluid, the protein, they all have different weights. So they'll separate out based on their weight. And the platelets separate out into this nice little white layer called a buffy coat, if you want to get technical. But we're able to separate the platelets out, and now they're very concentrated. So you have concentrated platelets, which means concentrated growth factors, which I like to use the analogy. It's kind of like Miracle Grow. It's like fertilizer, but it's really strong. So it's like Miracle Grow. And then we take the platelet-rich plasma that we concentrated and we inject it into the area where there may be an injury, like a sprain, an injury to a ligament. There might be a strain, an injury to a muscle or a tendon. Those are kind of more acute or more recent, or it might be something chronic like arthritis. It might help with surgery. If we have a surgery and we repair a meniscus cartilage, it might help that heal. So it's basically growth factors that are supercharged and concentrated, kind of like Miracle Grow.
Gotcha. Okay. What about BMAC? How is that the same as PRP?
So BMAC stands for bone marrow aspirate concentrate. If you want to get technical, some people you say bone marrow aspirate cells. Either way, it comes from the bone marrow. So our bone marrow has stem cells and it has many other cells that help the stem cells. Stem cells are cells that can turn into anything. They can turn into lung, heart, liver, cartilage, tendon, muscle, um, bone. And so in our body, every day when we walk around, I'm simplifying things, but we kind of get little microscopic cracks and breaks and we beat our body up. Then we go to bed at night and our bodies heal ourselves. And the cells do the work. So the stem cells are what do the healing and the repairing, and the growth factors from the platelets and a lot of other areas help feed those cells to do what they need to do. We know that as we get older, and I alluded to this, that we don't have as many stem cells in our arms and our legs. So we don't have as many repair cells. So our knees might start to break down, or our shoulders might start to break down, or our bodies start to break down faster than we can repair ourselves. And we start to get little microfractures or strains or sprains or overuse injuries, tennis elbow, things like that as we get older. our bodies still have a good ability to repair ourselves, but it definitely slows down as we get older, especially if we don't eat the right nutrients, we don't have the right
Mhm.
diet, we get overweight, we eat too much sugar, we don't exercise, our muscles get weaker. That's going to cause more of that wear. That's going to even add more to that wear and tear. But the bottom line is not having enough stem cells in our extremities does cause us to start breaking down faster than we can heal ourselves. So there are certain areas of our body, like the pelvis, which still have really good stem cells right up into our 80s. So if we can take good stem cells from an area that's pretty easy to access, it's not your spine, it's not your hip, it's your pelvis right in the back of the kind of above your butt. There's a couple areas you can feel. They're called your PSIS, your posterior suprailiac spine, and we can numb the area up. And literally in the office, we can put it. It's a little bit bigger needle than the needle you would get for a shot, but we put a needle in there and we are able to concentrate and draw out the bone marrow aspirate, which has stem cells and other cells that help the stem cells. And then we are able to inject those into other areas of the body that need healing. In our experience, and also I think if you look at the research, the cells do the work, and the cells tend to work better than quote unquote just PRP. As we get older, our platelets aren't quite as good. So when you're in your teens, the platelets are very, very powerful, and sometimes you just can do fine with just the PRP. As we get older, 30s, 40s, 50s, definitely 60s, 70s, 80s, 90s, the cell therapy, in addition, we always use the PRP with it to help supercharge those cells. It really works better. And also for the bone, you need to use the cells, like the Dr. Hernigo study that we talked about with the knees last week. And so it's completely different than PRP, but it's kind of all under the same category of regenerative medicine, ways we can use our bodies to help heal ourselves.
Gotcha. Okay, so I heard you reference the Dr. Hernigo study. I heard you say evidence, but I also heard another doctor say there's no evidence for stem cells. So why do they say that?
Well, in our training, I mean, I'm a fellowship trained sports medicine orthopedic surgeon. I'm also a regenerative medicine expert. In the standard, at least, I don't know about exactly how it's going nowadays, but I kind of have talked to some of the younger docs, and I think they know less. I hate to say that, but than we even learned in our residencies and fellowships. And part of that is the hours are restricted. Like we had to work, 100 hours a week many times. They
Mhm.
don't get as much experience. A lot of orthopedic residents are coming out of 5 years of training, not feeling confident they can go do a surgery on their own yet. So they have to they go do a fellowship to learn how to operate. A fellowship's an extra year of training. It might be in sports medicine or joint replacement surgery or hand surgery or pediatric orthopedic surgery or whatever. When I came out of residency, we had tremendous training with being able to operate, and I had no problem with that. I went into sports medicine to specialize in minimally invasive surgery, little tiny poke holes, and sports medicine. So that was an extra year of training. I did that with Dr. Andrews, who's the greatest sports medicine doctor of all time. So I was very lucky I was able to do that. But what happens is there's not a lot of training on necessarily regenerative medicine when you're in a surgical specialty of training. And so on my first day of even when I was in medical school, I went to the operating room to watch a knee replacement. And I watched it and I thought it was pretty cool. Like they're using saws and drills and hammers and they're replacing the ends of the damaged bone where the cartilage had worn down with metal, plastic, and cement, putting a metal cap on the thigh bone, putting a little metal plate with a plastic on the shin bone. And who would have ever thought of that? But I remember asking the question, uh, is there any way to repair the knee or grow back cartilage or cure arthritis? And I just remember the chief resident, who's in their last year of their training, pointing at me and saying, "No, there's no way to cure arthritis or grow back cartilage or repair a knee." And so that's kind of where I got the idea in my head. There's got to be a way to repair the knee and not replace it. So that also ties into your first question. But I think the main issue is there's not a lot of training on it. I was lucky when I did my fellowship that I was exposed to a doctor, Dr. Bradley, who was the team doctor for the Pittsburgh Steelers, who was doing regenerative medicine techniques even back 90s, 2000s, even if people remember if they're Steelers fans, which I'm not a Steelers fan, but anyway, if you're Steelers fans, Hines Ward was a great wide receiver for them. 2 weeks before the Super Bowl, Their second Super Bowl he won. He tore his MCL, which is one of the ligaments along the inner side of the knee, the medial collateral ligament. And normally there's no way you're going to get back in 2 weeks. But Dr. Bradley injected him with PRP back then. That was like, I think 2003 or something like that. And he was able to heal and play in the Super Bowl. So that was kind of a big jump start for this regenerative medicine. And some doctors just buried their head in their sand and said, I'm not going to do shots. Other doctors like myself are more like, hey, I was already trained on minimally invasive surgery, little tiny poke holes with Dr. Andrews. And I was always a Star Trek fan, and I liked how Bones McCoy had a tricorder, and he could look at people and diagnose them without cutting into them or putting needles in them, and then he could heal them or treat them with this tricorder. So I've always kind of had that. Hey, if we can get people better as minimally invasive as possible, or without any invasiveness, like what a laser does. I mean, the PRP and the bone marrow are shots, but the laser is no shots, no needles, very, very safe, and it helps your body heal itself. So I'm going off on a tangent, but the bottom line is I think that people say that because they don't know. And the Dr. Hernago study, I guess I'll repeat it again really quickly here. I mean, this is in the late 90s. So anybody who says there's no evidence, I mean, this study was done in the late 90s, early 2000s. Minimum of 10-year follow-up. Some of these people 15, 20 years, and even longer now. But the study came out in 2020, and 140 people, they needed knee replacements on both sides. Both knees were terrible. He says, we're going to do a knee replacement on one knee. We're going to do the stem cells on the other knee. Bottom line, the people who got the stem cells, 82% of them didn't need a knee replacement for 10, 15, 20 years on average. Crazy. So
Wow.
there's massive evidence, like really good scientific evidence that stem cells work. Massive amounts of evidence, but they just don't know about it. As a matter of fact, there's really good evidence. So if you look at just PRP, we were just talking about that, platelet-rich plasma. There's probably over 40 now, but there's at least 37 definitely level one, level two, the highest level studies you can have. There's 5 levels of study, not to geek out here, 5 levels of research. 5 is the lowest, 1 is the highest. There's at least 37 studies in level 1 or level 2 that show that PRP by itself is better than cortisone injections, which are horrendous, gel injections, hyaluronic acid, the rooster comb injections,
Mhm.
standard physical therapy, and even arthroscopic surgery, the little poke hole stuff that I do. So for arthritis. So there's a lot of evidence, and the people who say that, they just don't know any better. That's the bottom line.
Wow, that's crazy. Um, you did say at one point you talked about Heinz Ward, and you talked about that he was able to get a PRP injection 2 weeks before the Super Bowl, and was able to play. A question that we had was in regards to bone marrow and PRP, how long is the recovery after bone marrow and PRP injections?
Tremendous question, and the answer there can be answered with a question as well. In that, what was the injury, right? So
Mhm.
now, if someone has really bad bone-on-bone arthritis, that might be something that's a different recovery. If somebody has an ankle sprain, that's a completely different injury. If someone has an MCL sprain, that's a different injury. If someone tore their rotator cuff, so all these injuries are different. So first of all, you got to figure out what's wrong. And that's
Mhm.
where we do something called what we call a comprehensive diagnostic evaluation. If you don't know exactly what's wrong, then you can't really give someone advice on how long it's going to take. And so what that is like I'll sit down or my orthopedic PA, Allison, who happens to be in the room here filming. Hey, Allison. And also our PA, Jordan, one of us will see you and we'll sit with you for an hour. I mean, the average amount of time that a medical professional spends with a patient nowadays in the United States is 7 minutes, which is just terrible. And so we'll spend an hour and we'll figure out, what have they had done? What was their injury? Really get a good history, get a good physical exam. I mean, how bad is the injury? Is it a partial ACL tear where we can maybe get them better, or is it a full ACL tear where we may have to do surgery and then we do the PRP and the bill? Like all these things matter. So you got to figure out exactly what's wrong first. And so first, the best way to do that is you got to listen. You got to sit and hear what the history is. Then you gotta do a great physical exam. Then you have to get the right diagnostic studies. Oh, I don't need X-rays. Yeah, X-rays are very good because they show bones, they show fractures, broken bones, they show arthritis. They show calcium deposits. They may not show if you have a torn ACL, but they might show signs of it. So yeah, there's certain things that X-rays don't show, but there's many things they do show. So we will always get X-rays. We always get the right X-rays. A lot of times the X-rays aren't done with the patient standing up, so you get faked out. You don't really see how narrow their joint is, and how much arthritis they have. You don't, maybe sometimes they don't get X-rays of the kneecap. Oh, there's no arthritis. Well, there might be a ton of arthritis under the kneecap, but they didn't get X-rays of the kneecap. So getting the right X-rays, and ours are digital, so they're very good quality. Um, Also, an ultrasound. A lot of doctors don't have ultrasounds, but we can look at that knee moving live. We can see if a meniscus is getting pushed out or pulled in, which is your shock absorber cartilage. We can see if there's fluid in there, if there's a cyst. We can make sure we know exactly where we're going to put a needle to either pull the fluid out or to put the healing PRP or the bone marrow cells in, so we can plan out things. So the patient and can literally watch as we do it live on the screen, and they can see, oh, this is the inside of my knee. That's really cool. And it's cool, but also we're figuring out what's wrong and making a game plan. And then an MRI. Well, I don't need an MRI. Well, I have arthritis. I know I don't. Well, if you think that you don't need an MRI, or you've been told that, that's because a lot of doctors don't realize that the bone is where the subchondral bone underneath the cartilage, is where the problem is with arthritis. And arthritis is nothing more than the cartilage on the end of the bone, which looks like the white on the end of a chicken bone wearing down. So an MRI is going to, yes, show you if you have a cartilage tear, a meniscus tear, which is the shock absorber cartilage in the knee. It's going to show if you have a sprain of your MCL, like Heinz Ward. It's going to show if you have a strain of your quadriceps tendon, a muscle tear, lots of different things, especially the soft tissues. It's going to show nerves. It's going to show fluid, blood vessels, all kinds of things. But more importantly, for what we do, if someone has arthritis, it's going to show that bone, and it's going to show if there's microfractures, which you can't see on an X-ray and you can't see on an ultrasound. So we do special sequences on our MRI scanner, which, by the way, is an open MRI scanner, and people love it for the comfort. If you have claustrophobia, it's great. People say, oh, it's not as good as a closed one. It's just as good. The software matters. It may take a little tiny bit longer, but we can get just as good images, if not better, for what we're looking at. And so what we're looking at is that subchondral bone. We do special images called STIR images. You don't have to know that, but we do have special images to look at that. So now you've got those diagnostic tests. Great. We're going to be able to kind of come up with a plan, but just examining someone briefly, and even a thorough exam, you need to watch them do you need to watch them dynamically, meaning functionally, like watch them as they're walking, watch them as they're lifting weights. Watch them as they're going up and down stairs. Watch them as they're lifting something like they would lift their laundry basket. All these things need to be checked out, because all those things can affect the knee. If you're doing those things wrong, or if you have an issue with your hip, or you have an issue with your ankle, even your Achilles tendon, if it's tight, it's going to put extra stress on your knee. So what we do is we don't have, quote, physical therapy where they only concentrate on the knee. We have this thing called VFit, Victory Fitness, where we do a holistic approach. It's a strength and conditioning, a total body fitness type of a evaluation. And all of our VFit experts are either doctors of physical therapy assistants, or certified athletic trainers like you, Adam. And then you all have higher levels of certification, strength and conditioning specialists, or even higher. So you have the fitness, the strength and conditioning, you have the medical degree. You guys are amazing at understanding all this stuff that I'm talking about. Like, you understand all this, which most fitness trainers don't. But you also have the fitness part of it, which a lot of physical therapists or athletic trainers are not, they're good at it, but they're not experts at it. And frankly, it's not their fault. They don't have time in the standard system to examine all the areas of the body. They can only concentrate on the knee. They get 20 minutes. We give you guys an hour. You have an hour to maybe you can go over this at some point too, but a whole hour to evaluate somebody and figure out, is their back affecting their knee? Is their hip affecting their knee? What is their ankle affecting their knee? Is their knee their main problem? Sometimes we see people who come in for a shoulder problem, right? And it's their neck, or they come in for a hip problem and it's their back, correct? So
Absolutely.
you guys get to spend an hour with them. And after we get all that done, we meet together and we talk. And we come up with a little bit of a preliminary game plan. But then we sit back down with the patient and hopefully their spouse or loved one or family member or friend. So we always want them to bring somebody, because it's always good to have a second set of ears and a support system. Very important. And we will sit down. We'll go over everything. We'll show them all their images. Like, when's the last time you went and got an MRI done and not only got the results the same day, read by a board certified radiologist and read by an orthopedic surgeon or an orthopedic or regenerative medicine specialist, and then also looked at the images yourself so you understand, oh, yes, I have these stress microfractures in my bone, and that's where you're going to put the bone marrow, and that's why it's going to work. And so we go through all that. And then we'll spend a lot of time trying to figure out what their goals are because some people come in and their goals are to walk up and down the stairs without pain, because my laundry's in the basement. Sleep, through the night without pain, without waking up my spouse who's going to kill me because they can't sleep because I can't sleep. Just going for a walk with their friends or walking the dog. That's one thing, right? There's people who want to get back playing pickleball. That's a little bit different level. There's people who want to hike up in the Adirondacks, which is in New York State, which is a lot of hills and mountains, and there's 46 peaks, and there's a lot of people who like to hike where we're at. There's people who like to golf, hunt, and then you got the people who want to run a marathon or something like that. And we have those people. So we're going to use the same principles, okay? And then we're going to come up with a plan based on what the top three goals are for that person. We're going to figure out what their top three goals are and what their expectations are, and we're going to come up with the right plan for them. Then we're going to kind of be able to give an idea of how long it's going to take to get better or not better from this. But in general, I would say if you're going to really go through a comprehensive program like that, and we're going to even analyze your diet and your genetics and make sure you're on an anti-inflammatory diet and maybe even use our V-Slim program, which is a red light laser, where, believe it or not, there's certain wavelengths of light which can open up the pores on your fat cells. And we have our fat is stored in cells, actually, fat cells. And there's certain wavelengths of light which can open up the pores. The fat will drain out into your lymphatics and you will eliminate it naturally. It sounds like science fiction, but it's real. It works. Well, because you run the machine. And so that is another thing that we'll utilize in addition to the genetic-based diet, decrease inflammation, because we really want the best healing environment as well. And I like the analogy of a garden. If you have too many weeds in the garden and you plant seeds or plants, those weeds are going to choke out, the plants, and you're not going to get as good of a harvest. Same thing. If you have too much inflammation in your body, we can do the bone marrow cells, we can do the PRP, we can do the VFit, but if you have too much inflammation in your body, you're not going to get it's like too many weeds. You're not going to get as good of a result. So we go with a holistic approach. So if you really want to go with the holistic approach, in general, it's going to take about a 12-week time frame. It's not like you're laid up I went through it for my elbow within 3 days I was operating. So it's not like if I had a surgery on my elbow, I wouldn't have been able to do my job for 6 weeks or so. But you are limited a little bit in the beginning. And the younger you are, and if it's more of an acute injury, like you sprained your ankle, you're probably going to be back to playing the sport you want to get back to sooner than that 12 weeks. But the whole 12-week thing is to get you better from whatever you're suffering from, right? Then optimize that. And then in the long run, maybe the last couple of weeks, 3 weeks, are to get you to the point where you're optimizing, you're preventing this from ever happening again. Or a lot of people, as soon as they get better, maybe they're 6 weeks, 8 weeks into it, and they're like, oh, I think I want to revise my goals. I think I don't want to just walk the dog. I want to start playing pickleball, or I want to do this, or I want to do that. So the answer to that question is it depends. But if it's someone who needs to get back to a sport right away, sometimes we can get them back in 2 or 3 weeks, but we would still want to work with them during and after that because frankly, the body takes after any injury or any surgery. I mean, the bottom line is it's going to take at least 6 weeks to really get. He played in 2 weeks and he was much better, but he wasn't 100%. But still, he wouldn't have been able to play at all. And we had a kid, by the way, just there's another example of this. We had a kid who, in 6 days before the state championship game for football, in the semifinals, he sprained his ankle. He had a high ankle sprain, which is even worse than just a regular ankle sprain. That's a whole nother subject. But we did laser on him every single day. He wasn't really a candidate to get injections or anything like that because he had to play in 6 days. So we did laser on him every day. We did VFit on every day, and he played and he caught 2 touchdown passes, and he would have never played. So he wasn't 100% in that 6 days, but he was 80, 85, 90% and ready to play. So we can help speed things up, but the body does take, in general, about 6 weeks to heal. In some people, it'll take longer as you're older, and some people it might be a little bit less as you're younger, if that makes any sense.
Absolutely. And that kind of goes into another question that we were asked. If I do these injections, do I have to stop running? And I think this comes from a space of maybe two different frames of thought, right? If you get a knee replacement, if you run on a knee replacement, it's not very good, right? And like, for how long do you think someone would have to stop running? I think you got into that a little bit, but just generally answering the question, if I do these injections, BMAC, PRP, do I have to stop running?
So, I'm a doctor and I'm also a runner. I run 7 marathons, so I can answer that question a couple ways. But in general, the answer is no, you don't have to stop running, which is great. So I was
Yeah.
hoping for some yes, no answers here. So I'll just stop there. Is that good? No, just kidding. I'll keep going. Um, but the answer is if, what's the question again, one more time specifically? Because it depends on how you ask the question.
Yeah. If I do these injections, do I have to stop running? That was the
Okay, so
question.
that also depends on what the problem is. If it was you sprained your MCL, there's no reason you're never ever going to have to stop running again. You don't have arthritis in your knee. If it's you, strained a muscle or a tendon, your hamstring, great. We can get you back to probably where you're 100% again. And the goal is to get you running again for sure. Now, if you have bone-on-bone arthritis in your knee and you want to get back to running again, that's a different story. So for an acute injury for someone who doesn't have arthritis, absolutely you can get back to running again. For someone who has mild arthritis, or they have meniscus tearing, sometimes if you have a meniscus tear, the shock absorber cartilage tear, and it's flopping around, that might even need surgery sometimes. Like I had that. I had one that wasn't going to get better with just injections. It was flopping back and forth and locking my knee up, and that needed surgery. So Dr. Andrews happened to went in there and trimmed it out because it wasn't repairable either. And then I've run several marathons since then. So even if you need surgery, et cetera, and if you don't have a lot of arthritis, you can usually get back to running. But let's talk about specifically people who have arthritis because I think that's really more, and that may be who asked this question. They just didn't qualify what the diagnosis was. But technically, as we talked about last week, there's no known studies that show that running in and of itself causes arthritis.
Mhm.
Having said that, if you have arthritis, meaning the cartilage on the end of the bone is wearing down, then there is some evidence that if you run, you can make that worse. Having said that, runners, as you know, you're a runner, I'm a runner. We're a bit crazy in the head, and we're always going to want to run. And it's good for our mental health. It's good for our cardiovascular health. It's good for everything. So I will always help people if they want to run. I'll qualify it, but I will help them get back to running. So I'd say the vast majority of times we can get them back, but there might be some modifications or it might take longer. And really, that's where you guys come into play, the VFit experts. The procedure of injecting the bone marrow, et cetera, that's really no different in whatever we do. It may need some injection into the bone, which is we do for people who don't want to run necessarily as well. So it doesn't really change necessarily what I do, but it changes really more what you guys do with your total body fitness, strength, and conditioning VFit, which is usually, we usually with these programs, it's 24, you have 24 visits. So the first few visits are going to be really just protecting that area that the cells were in, kind of like if you're growing grass seed, you're not going to like play a football game on the grass right away. You're going to let the grass start growing. You're going to keep the dog off it, keep the kids off it. You're going to protect it, but you're also going to take care of the areas around it because you don't want weeds getting in there, and you're not going to let the other areas, you're going to want to trim any branches so that the sun gets on it, so it grows. So the point is, you guys will be working on the rest of the body, protecting that knee, working on range of motion, simpler things, and then as time goes on, you'll start doing more strengthening specifically for that joint. Then, as time goes on, you'll start getting more into pre-functional activities where you're working with maybe both legs, trying to get everything stronger, including upper and lower body. But then you start working on single leg to get that one leg that if it's both, sometimes it's both knees, by the way, right? But you'll start working on single leg. So you got to master, you got to go through certain steps. You got to make sure that you got your range of motion back first. You got to make sure there's not too much swelling or inflammation. Once you do that, then you work on certain easy strengthening exercises, and you got to pass that. Once you pass that, you got to master double leg, both legs at the same time, like squats and other things that you do with both legs, strengthening exercises. Then you move on to single leg because when you're running, right, you're one leg, when we walk, everything, one leg, one leg, one leg. And so then you got to master getting stronger on individual legs, one single leg on both sides. Once you get to that, and everything's responding, and if you passed all the tests, you have full motion, your knee's not too swollen, then you can start the jogging and the running and the more functional stuff. So that's kind of how the progression goes. Some people can speed through faster if they're younger. Even if you're older, you can sometimes speed through faster if you don't have as bad of an arthritis. So it just depends on a lot of things, but that's why it's so important for that CDE, like that comprehensive diagnostic evaluation, figuring all that stuff out ahead of time, because I can't give someone an answer to that question unless I know all the pieces of the puzzle first. And that's why that CDE is so important and in answering that question. That's why if you come in one day, we can get that all done. I didn't really mention that, but you can get all that done in one day. There's no way in the standard system that you can get that all done in one day. It will oftentimes take weeks or months to get all that stuff done. So we get it all done in one day. We get you a plan and get you those answers to that question.
Excellent. Yeah, yeah, yeah. Still looking at my list here. Oh, we missed one earlier. What is therapeutic laser and how does it work?
Yeah. So there are certain wavelengths of light which our bodies respond very positively to, just like you have certain wavelengths of light that plants respond positively to, and that's called photosynthesis. There's a thing called photobiomodulation, kind of a big word, but our bodies respond to certain wavelengths of light in a healing manner and in an optimization manner between like 600 and 1200 nanometers, let's just say, or 600 and 1000, but there's certain invisible wavelengths of light that can penetrate through our skin, believe it or not, and can affect our cells in a positive way. So they're influencing our cells to work better. And if people don't believe this, a simple test is there's a week where it's cloudy all week and you're going outside and you're doing whatever, and then you finally get a sunny day. You go outside, how do you feel? You feel amazing, right? Because
Mhm.
the sun has way the sunlight does have a positive effect on our mood, on our cells. Obviously, there's other wavelengths of light in the sunlight which can cause a sunburn and cancer and all those other things, right? But there's certain wavelengths which are very therapeutic. So people figured out what those wavelengths were, and we know that there are certain wavelengths of light. In particular, our laser has an 808 nanometer and a 905 nanometer. We don't need to get technical, but the point is a lot of lasers are one wavelength of light. Ours actually, the one we use is an MLS laser, which actually has two wavelengths of light, and it's multi-wave, so two wavelengths locked, meaning they're locked in a certain, synchronized in a certain way system, MLS. And so they're locked in a certain way that is proprietary. But lasers, you hear about lasers, you're like, oh, you think of like Luke Skywalker and stuff like that. Like, is it going to burn me or whatever? And yes, some lasers, if you're not careful, if you don't move them fast enough, they generate heat and they can burn, even though they have the right wavelengths. Well, the laser that we have has specific wavelengths, and especially the way they're locked together, where it's very safe and it will not burn the person. So there's no needles, no shots, no known side effects. It's very, very safe, cleared by the FDA since 2009. We've been using it since 2017. And the laser does four main things. Pretty easy. Number one, it stimulates the mitochondria. So most people out there remember the mitochondria from high school biology. If you don't remember it, it's the little powerhouse of the cell, kind of like the batteries of our cells. And the light energy, those recharges the batteries of our cell and makes our cells work better. That's number one. Number two, decreases swelling and inflammation. So if you have an injury, if you're going to get swelling and inflammation, it gets that swelling down quicker, which helps your pain, but it also
Mhm.
gets the bad stuff out so the good stuff can come in. So how does the good stuff come in? It increases blood flow. So it increases blood flow to the area and that helps it heal. And then the final thing is it actually has a direct pain relieving effect. So it can inhibit the painful nerve fibers, the nociceptors that cause pain. So the laser does those four things: stimulates the mitochondria, decreases swelling and inflammation, increases blood flow, and decreases pain. It's amazing. It really works. There's a ton of studies on that too, because you get a lot of, oh, it's not proven baloney. There's a ton of studies that show that laser light energy has a very positive effect on many, many things, including humans.
Yeah, yeah, for sure. Thank you for
Sure.
that.
Thank you.
Um, so I have two questions that I think could be answered together. Um, and I think you alluded to this a little bit earlier, but not bad to revisit the specific wording of these. But here's the two questions. If I want to come in and just do a PRP injection, do you guys do that? That's the first question. The second question is, I heard you could do just PRP for pretty cheap. Should I try that first before I do all this other stuff, aka our knee repair, not knee replacement program? Um,
You use
the
the word
floor is
cheap.
yours.
That's not a good word, right? I mean, you kind of get what you pay for. I'm just gonna say, I mean, cheap is probably, I mean, would you trust your, mom's life or your grandma's life on something cheap,
Mm-mm.
right? So there's not all PRP is created equal, I guess, is one thing. So yes, platelet-rich plasma. I think the technical definition is twice the concentration of platelets that are in your blood. I think most people realize that even that is not very therapeutic. So when we
Mhm.
spin it down and we concentrate it, I mean, we're looking for, I mean, a minimum of 4 times, but I mean, you want to get up to like 8, 9, 10 times the concentration of what's in the blood to really get a therapeutic level. And you also need to know that I mean, you don't need to know this as a person, but as a provider, they need to know this. And as someone thinking about getting PRP, some questions to ask are how many cc's of blood are drawn? Because studies have shown you need a minimum of 60 cc's to guarantee you're going to get the right dose. Because just like anything else, there's a dose. You need the right dose of platelets. We know from amazing studies from amazing doctors out there that you need 10 million platelets to be therapeutic for a knee arthritis injection.
Mhm.
Billion, that's 10 billion. I think I said billion. You need 5 billion, at least 5 billion or more for a rotator cuff shoulder injury. So we know there are certain dosages you need, and we know if you're not drawing at least 60 cc's of blood, you're not getting that dosage. That's the bare minimum. So there's a lot of kits out there where they say, oh yeah, you can draw 15 cc's, like a little syringe of blood this big. You're not going to have, that's not PRP. You're not going to have enough platelets. So it's
Yep.
like taking a quarter of a Tylenol and you can take a quarter of a Tylenol every day, and it's not going to do anything for you, right? But you have to have the right dose. Now, people, well, is there too much? Can you overdose on it or whatever? No one's really found that you can do too high of a dose of PRP, but you don't need the point is you don't need to draw like 2 gallons of blood. That might be overkill, right? Spin it down and get so much. You don't need that. You need 60 cc's up to maybe 120 cc's, depending on what your area you're doing it in and how many areas you're injecting. Okay. So how much blood is being drawn? That's a huge thing. A lot of doctors have no clue. Their nurse does it. They just do the injection. Um, leukocyte rich or leukocyte poor. I know that sounds like fancy words, but all that means is are you going to have white blood cells in that mixture with the platelets or you're not going to have white blood cells? If it's a chronic problem, meaning like a tennis elbow, it's been there for years, you want to kind of restart the healing process. So you actually are going to want white blood cells in there, which actually restart the healing process and cause inflammation. Inflammation early on is actually a good thing. Chronic inflammation, long-term inflammation, bad. But for a couple weeks, it's a good thing if you're trying to restart a healing process. So if it's
Mhm.
a chronic, meaning long-term problem, you are going to want leukocyte rich. If it is a problem where there's already inflammation because the injury just occurred, you don't need to put more inflammation in there. You just need to put more growth factors in there. So that would be leukocyte poor, no white blood cells. Do you want to put PRP that's going to cause inflammation inside the knee when the knee's already inflamed? No. When someone has arthritis, you don't want leukocyte rich, you want leukocyte poor. And I'm being kind of simplifying things, but that's really important. How many spins? Okay, on how many spins? One spin, two spins, three spins? That's kind of controversial. I have my own thoughts on that, and there's certain standards for that. What speed do you spin it at? Um, and then are they injecting it with ultrasound? Are they using ultrasound, and what's their technique? Are they just putting the shot in there, or for like a tennis elbow, you need to put it in multiple spots and poke it in multiple spots. Whereas in the knee, you might just need to put it inside the knee and let that circulate through the knee. Or guess what? I'm going to go get PRP in my knee. Oh, well, do I need an MRI, doc? No, you don't need an MRI. I can tell from your x-rays you have arthritis. Okay, great. So you get the injection in the knee, intra-articular, between the bones, not in the bones.
Hmm.
And it might help a little with the arthritis in the knee, but what if you didn't get the MRI? What if you did get the MRI and it showed all those stress or microfractures like Dr. Hernigo's study, and you didn't inject those areas? And by the way, PRP doesn't work that great for that. You need the bone marrow for that. But even if you don't recognize that there's a problem in the bone and you only inject inside the knee, you're doomed to failure. It's not going to either work as well, work at all, or it's not going to last as long. So there's so many factors involved. So you absolutely, cheap is a terrible word. I like to use the word investment. Lower cost, you might be able to say, but if someone's saying we're cheaper than hey, come to us, we're cheaper, they probably are cheaper. Don't run for the hills. If they're not injecting it with ultrasound so they can see precisely where to inject it, um, then run for the hills. You're going to put that money into it. You want to put in the perfect spot. That's why we use ultrasound. We're very skilled at that. Um, and so, as far as the other question, I think was, should I go with a PRP only before I do everything else? Is that
Yeah.
accurate? I think the answer to that is really simple. Like, how do you know what to do, and how do these doctors know what to do without really getting a full picture, like we talked about? It goes back to that comprehensive diagnostic evaluation. It's an investment, but at the end of it, even if you decide I'm not going to do anything, you'll have everything you want. You'll know everything about what's going on. You'll have a diagnosis whether you want to do the plans or not, you'll know exactly what's going on, and you'll get that all done in a day, maybe 2 days at the most. So you'll know what's going on. I can't tell you how many people come to me and they've had X-rays, MRIs. They have no idea what they showed. They were not gone over with the doctor. They say, "Oh, well, they never called me, so I assume it's okay." Right? That's a bad thing. All you people out there, if someone tells you, if you assume that no news is good news, don't assume that. Always, if you have a set, I don't care if it's lab work, blood work, X-ray, MRI, CAT scan, if get the results, okay? Because doctors are busy, their offices are busy. Sometimes the radiologist doesn't get the report to them. It goes by the wayside and something gets missed. This way, if nothing's getting missed, we're doing it that day. You're getting it that exact day. Nothing's going to get missed. Okay, there's no way because you're going to see it. You're going to be here for it. But even if you do it somewhere else, make sure you get those results because that's really important. And if you don't know what the problem is, if you don't, if also have they sat down and really gone over what your goals are? What are your goals? Did they even ask you that, or they just said, "Oh, you have knee arthritis. We're just going to inject your knee." Then, if they don't know
Yeah.
what your goals are, how do they know how to treat you and how do they know how to speed things up or slow things down or whatever? So
Yeah. And
I think
I think what you're saying kind of goes back to, when uh, knowing what the goals are, knowing where to inject the PRP. That's why people, depending on where you go, you might have a varying success rate, right? We know our success rate. We track that information, right? But if someone is just, not injecting under ultrasound guidance, not knowing exactly where to put it, that's where you can run into those varying degrees. Because I mean, we've heard people say, "Oh, I've tried PRP in the past and it didn't do much." Right? But what you're saying is it really matters the proper diagnosis and the proper location, knowing exactly where you're supposed to put it and actually treating the problem and not just putting an injection in, right?
all
So
the more so even with PRP, like you're like the PRP is not going to migrate to if you put it in the wrong spot, it's not going to migrate to the spot where the problem is if you don't know where the problem is. Cells might do that. You might get a little bit away with that with cells because they can move around. But if you put the PRP in the wrong spot, then it's not going to do anything for it. It's not going to magically go to the spot where it's needed. And I think you mentioned something that's very important. I would also go ask, I'm going to go down the road and get it for cheaper. Do they track results? Are they tracking their results? I mean, every single patient who we do one of these programs with, we track their results in a national registry. It's called Data Biologics. And we look and there's over 20,000 patients in that. And it's from regenerative medicine and similar offices around the country. So
Mhm.
there's multiple different offices. We can track our results against ourselves because we're always trying to get better. But when we track our results against the rest of the country, we're always quicker to get pain relief and faster to get function and over time. So we're always better than the national average. Not that we don't even want to continue to get, even quote more better, there's such a word or two words, but we perform higher than the average in the country by far. So we know we're better. Um, we're not being cocky. We have results that show that. And then is it 100%? No, nothing's 100% except after taxes. Even a knee replacement, 15 or 20% of those are not going to do well. They're going to fail.
Mhm.
And so with any surgery, a success rate of 85 to 90 to 95% is considered very good. So our results are very comparable to that. We like to say 85 to 95% of people usually get 85 to 95% better. It's not 100%. Always going to have some disappointments or things that don't work, but then at least you know and you didn't burn any bridges. You do a knee replacement, you get a knee replacement, and it doesn't work. You're one of those 15%. You're done. You got metal, plastic, and cement the rest of your life. If this doesn't work, then you still have options. And I will give an example of this. This just happened recently. So, do we have failures? Absolutely. Absolutely. I mean, even if you're a surgeon and I've been in practice 26 years, of course, even you're going to have surgeries that don't work. That's just normal. No one's 100% perfect. So we just had a lady recently, last year, she came in, she had like one of the worst arthritic shoulders we've ever seen and really bad. Now, we've had some good luck with those, actually, to be honest with you, which is crazy because you never think it would work. Even I didn't used to think it would work. And when we started doing this on people and it was working, that's one of the things that got me so excited about continuing on
Mhm.
along this regenerative medicine path. But in her case, really, really bad arthritis. And she underwent the whole program. She got 30% better, but she's not, where she really wants to be. And we did tell her ahead of time, hey, this is really bad arthritis. You should probably get a shoulder replacement, but she didn't want it. Now, if she got the shoulder replacement at the time and that didn't well, she'd probably be kicking herself. This way, she did get better. Her motion's better. She still has a lot of pain because she has really bad arthritis. And she probably needs a shoulder replacement, but she's still choosing not to get one. So she's 30% better. And if she ever wants one, she can still get one. Whereas if she had gone with the shoulder replacement, she'd be stuck with one if it didn't work because they don't always work either. So
Mhm.
at this point, I don't think we had anything more to offer her other than now she knows she's going to keep doing her exercises, keep doing her range, keeping her range of motion, and therefore, if she ever chooses the shoulder replacement, she should do better.
Absolutely. Um, I got a few more questions. Again, I might have to push some towards next week, which is totally fine. We do these every week between 9 a.m. and 10 a.m. Eastern time.
By the
So
way,
some
if people out
questions.
there want us to do a different time or there's a better time, let us know. We'll be more than happy to, modify it, or we can run replays or something like that. I'm not really sure, but I'll leave that to Adam.
Yeah, yeah, yeah. Um, how can I tell if I have a broken kneecap? This was submitted on, I believe, YouTube. So,
This is great because we just did it. So go to YouTube. So first of all, Victory in Motion is on Instagram, Facebook, TikTok, YouTube. Dr. Pietropaoli is on Instagram, YouTube, TikTok, LinkedIn. So you can go to any of these platforms and watch tons more if you want to geek out, tons more videos of not only just me talking, but we have a lot of testimonials, a lot of patients. I think I would recommend going and listening to what they have to say because it gets boring listening to us say the same thing over and over again. But when you hear from real people, and maybe at some point we'll have some patients come on the show. I think that's a good idea. But we just did a post on that. So if you missed this, or even if you that makes no sense because if you missed it, you wouldn't know this. But if you don't like my answer here, then you can watch that because it's better because we show the x-rays, we show the MRI and all that. So A, go to the YouTube channel. B, how do we tell? Well, if someone broke their kneecap, well, first of all, the kneecap is the patella. It's that bone in the front of the knee. And
mhm.
if you fall on it, you can break it. And living up north here in the ice, people slip and fall and break it all the time. You can also injure it and break it playing sports. We see it in football. We see it sometimes when we've seen it in basketball players. They go to jump and their kneecap breaks apart. Now, that's not going to happen unless they've already got like a stress fracture in there from overuse, which is if you watch the YouTube video, that person kind of had a micro fracture that wouldn't have been seen on x-ray. So what I'm getting at is you get an x-ray first. I mean, x-rays are going to show fractured or broken bones the best, especially if it's a displaced or separated fracture, it's going to show it. So you need an x-ray. That's how you diagnose it, number one. But you wouldn't just say, oh, come in and get an x-ray. We would listen to their history first. We would examine them because a lot of people think they broke their kneecap. They actually tore their patellar tendon, their kneecap tendon, or their quad tendon, and it wasn't actually their kneecap. So they need a different type of surgery. Or maybe their kneecap dislocated. So I think the other question that went along with that on the YouTube was, what happens if I sprain my knee or
Mhm.
kneecap? So it can also be they think they broke their kneecap, but their kneecap actually slid out of place and popped back in place. And that's different. And we can diagnose those that with x-rays and with MRI. So the x-rays, the getting in, listening to the history, getting a good physical exam, that's going to give us a great idea to start with. A lot of times I already know before I get an x-ray, but then you're going to get the x-ray for specifics. And the x-ray will show the bones are probably separated or there's a crack in the bone. Bone is white. You'll see a black line through it if it's a fractured patella, kneecap. If it's a dislocated patella, you might see evidence of fluid in the knee. It's better, easier to see that in an MRI, but you might also see the kneecap is tilted off to the side, not perfectly centered, and that might give you a hint that, hey, this was maybe a dislocation rather than a fracture. You can have both, by the way. And then most of the time we're gonna. I mean, if it's an obvious fracture where it's completely in two, you may not need an MRI. But sometimes we'll still get an MRI because you might have other damage in that knee. And if you're going to be going in there and doing surgery, wouldn't you want to know if there's a meniscus tear or something else going on as well? So most of the time we'll still get an MRI anyway. But if the X-rays look normal, which in the video we posted yesterday, the X-rays look normal, and this person found they had a ton of pain, ton of tenderness. So we did the MRI, and the MRI showed that they had microfracturing, almost like what we were talking about with the knee, but this is a traumatic microfracturing where the person fell and they got little microscopic cracks and breaks in the bone, and it was weak. And if we had just not gotten the MRI and we just said, hey, you don't have a fracture, go do what you want, and then they either tripped or fell again, or they tried to run up the stairs, they could have completely broken apart. And that's what usually happens in basketball players. They, from overuse, they get a stress fracture, they go to
Mhm.
jump up and the bone breaks in two. So in this case, we could see that the bone was lined up perfectly. It was weak. It was microfracturing. So we treated that person with a brace for a couple of weeks to let that start to heal. We treated him with laser. You can inject PRP and bone marrow cells for fractures too, especially sometimes when we'll repair something, a tendon or a fracture. You can inject it in there after you get the repair done, and it helps it heal faster. We also looked at the ligaments where the kneecap attaches. Ligaments connect bone to bone, and ligaments look black on an MRI. And so the ligaments were not torn on this person, but an MRI is going to show you that as well. So get a good history, get a good physical exam. Most of the time, you're going to have an idea at that point, and you won't be biased by just looking at the x-rays first. Then you get the x-rays, then you probably will need an MRI as well. And that's how you
Yeah.
diagnose it.
Perfect. Yeah. And
Comprehensive.
go back to that comprehensive diagnostic evaluation you talked about for sure. So, well, all right. Looks like there are a few questions I will send to next week. But as I said, if you're seeing this on YouTube, be sure to join our group. Got a problem with your knee? Ask Dr. P. It'll be down in the description. If this is on Facebook that you're seeing this, it'll be in the Facebook post. Just click on that link, join the group. It is free right now. So take advantage of that. Um, every Wednesday between 9 a.m. and 10 a.m., we are doing this live segment ask or answering your questions. Um, so thank you for those who submitted, and I look forward to looking at the new submissions coming up this week.
Thanks, everybody. Thanks, Adam. Appreciate it. Great job.